Good morning. My name is Quinn Throckmorton. I'm with the Campbell Clinic, and I'm going to continue the sort of post-traumatic or traumatic theme that we have for total elbows here today, because as great as the DMARDs and the anti-TNF drugs have been for rheumatoid arthritis, they've been really bad for our total elbow business. So as I think a lot of us are aware from the literature, a lot of our total elbow business now is from trauma and post-traumatic disorders. So that's what we focused on here this morning. So this is a 51-year-old man who has a very complex history. He had a work injury in 2008, and he was actually physically on fire and had a 80% total body surface area burn. Spent 4 months in the burn unit in Memphis, and then he, as might be predicted, had very significant HO. So he was then treated by the burn unit staff with a resection of his HO, and sadly this was the outcome. So he presents to our clinic in 2010 or 2011 with elbow pain and instability, and he has though his skin grafts are supple, he has skin grafts basically all over that arm and really all over his body. He's nearly blind. He had flash burns to his face and such, but has lots of pain and just can't use this arm at all. So I think we can go through the same options that Dr. McKee talked about. Is a soft tissue reconstruction worthwhile even thinking about in a younger person when it's this chronic? We didn't really think that was going to be all that helpful. When I talked to some colleagues about this, a lot of people said fusion, and I don't think that that's unreasonable. Resection is also an option, is really an end of the road, of course, if everything else fails, and then of course total elbow arthroplasty. So it was a couple of visits to meet with this man and talk about what he needed and what he wanted, and we elected to move forward with the total elbow. So we used this was before the NextL came out. I was actually trying to keep him off, and say, just give me a couple months until this thing comes out, and he didn't want to wait, and so we ended up using the Coonrad mooring. But I think there were some important technical tips that came out of this case. You'll notice the absence of condyles on the humerus now. So the joint had been dislocated for such a long time that we had to shorten him about 3 inches, or I'm sorry, it's 2 inches. We had to shorten him significantly just in order to get the soft tissue tension correct. So yeah, when you're doing these total elbows, I think Mike talked about it, and then Mark did as well. They talked about a generous release. I actually talk about it as skeletonizing the distal humerus. So I take everything off from the condyles all the way up to about 4 or 5 centimeters north of the joint line, and especially in a post-traumatic case like this where there are contractures and all sorts of potential soft tissue problems, get all the soft tissue off the humerus, and that will enable you to do the reduction later. And that was one of the keys, I think, that we found when we were looking up post-traumatic total elbows, is that one of the problems that you have is soft tissue contractures, and when you're really working so hard to just pry the humerus and the ulna together and then link it together, and you sort of say, hey, that's great, you don't really I don't think it was really understood at that point that you still have a lot of forces going across that joint. You don't have a truly balanced joint. You just have a linked joint, and that's why they were tending to wear out earlier. So we ended up shortening him significantly, and then he's at 3.5 years out now. He has mild pain and a functional range of motion. So he's 55 now. I'm not sure I would spike the football on this. He's got a long way to go, and I think he and I are going to get to grow old together. But nevertheless, I think in the short term, this represents a nice example of how a total elbow is a solution for a problem that really doesn't have any other solution that will give a good functional outcome. So I think this is a good way to sort of segue into a discussion about how the NextL, what advantages or what differences it might have versus the Coonrad mooring. And I'll bring Dr. McKee in to talk about this as well. But there's a couple of things, I think, certainly relative to little old ladies that want to split a lot of wood, or 51-year-old guys that want to be productive in society, is that a 10-pound lifting restriction. I still have them on that, but the NextL is a heavier implant, and it does have a vitamin E poly in the bearings, which for those that are familiar with hip and knee arthroplasty and some of the work that's been done in reverse shoulder arthroplasty, vitamin E poly really has very significantly improved wear characteristics compared to even highly cross-linked poly. So that's a potential advantage as yet not clinically investigated, but it's certainly something that I think that Mike and I would both hope allows us to increase activity levels in these patients over time. Mike, do you have thoughts on that?
I don't have much clinical experience with the new elbow. I will say that the primary advantage of the new design is to decrease the amount of load upon the polyethylene. And that's an entirely biomechanical data. There's not clinical data. So it is probably a good thing, since we know that that poly wear is in general bad and can lead to loosening, and there's a lot of force on it. So a design change that decreases the poly wear so clearly and unequivocally is probably going to be good clinically in the long run. The downside is that the orthopedic literature is full of great ideas in the lab that don't pan out in clinical patients. And that can be in arthroplasty in general or in total elbow arthroplasty in particular. So there have been many design changes, such as the original resurfacings of the hip or some of the more recent metal-to-metal designs, or metal back cemented acetabulum. Well, they all had great theoretical ideas and great biomechanical or lab data to support them. And then when you actually put them in a living patient, it crapped out. And there was a version of the TEA back in the day when they put a PMMA coating on it, and that was worse. That was a design change which was theoretically great, but didn't pan out. So I view the new system with a great deal of optimism, but also some skepticism. And I think that there needs to be some good preliminary data supporting the use of it before everyone switches entirely to doing that. And hopefully there'll be some good prospective trials and comparative trials that will tell us what's going on exactly. So very promising, but there are a lot of promising things like a first-round draft choice in the NFL or the NHL, and then when they actually have to play in the big leagues, it doesn't always pan out. So you don't know whether you have a Peyton Manning here or a Ryan Leaf at this point.
Or Johnny Manziel. And one last technical thing that Mark touched on a little bit, but it was actually something that I view as one of the most important technical improvements of the Nexel over the Coonrad Mori is in the instances where the condyles are on, those of you who do total elbows probably recognize that if you're going to try and do it all in one cementation, you fill up the humerus and the ulna, you put the components in, then you have to link and then hammer the components in, the humerus in, while the cement is setting up. I mean, that's an awful lot to ask with one cementation procedure. One of the advantages of the Nexel from where I sit is that you can put in the humerus and the ulna under no rush whatsoever, wait for the cement to set up, and then you can link after the components are in position, and that's whether the condyles are there or not. So the set screws that Mark Mori showed you there, those can be put in on each side of the triceps, whether the condyles are there or not. You can link in a completely unrushed fashion, and I've been there on a first generation or second generation total elbow when the cement is setting up and you're hammering real hard and you don't get the humerus down as far as you want, and that's happened to me. So I think that's something something that I view as a real advantage with this new system, is that you can put the components in an unrushed fashion and then link at your leisure. And I think that's all I have, unless there are questions from the audience, perhaps. Mark.
I have a question sort of about the traumatic cases, and the case you showed was really interesting. So when you have someone who is stiff and you're trying to deal with their stiffness but you want to balance the joint, so in the case you just showed, Quinn, you took off some humerus and you shortened the person. So at what level of loss of motion do you start taking away humerus, and how worried are you that as you start to change where the joint center line is, that it's going to impact on the longevity of the device because of forces that might not be isometric?
Really good questions, and I think from a technical standpoint, I was just trying to get the elbow together. I mean, it was it was the first thing I did was take the condyles off, and then I sort of shortened just to try to get it loose enough so that I could put the components together and get out of the OR that day.
But if you had we had a case on Monday where I could get the arm lacking about 15 degrees, maybe 30 degrees lack of flexion. I couldn't get it all the way straight, but I'd already shortened a little bit, and I was concerned that if I kept shortening it, so I just didn't know if there was a number, because you got it all the way straight, it's 0,
Yep.
right? So was that what you were aiming for, to shorten it until you get the arm fully extended?
Yeah, I think I got lucky with just how much I took off, and it ended up not being too much or too little. But if I was in that situation that you described where you're at 30 degrees, I'd probably plan on them perhaps getting a little bit of extra stiffness from whatever I get in the OR. So I think if it was somewhere around 15, I would probably accept that without running into and try to mitigate those risks that you talked about with excessive shortening.
The thing I'd say for that is it depends if the condyles are still on or not. So as you start to shorten, then you're going to lose your condyles at some point. If your condyles are still intact, and if you think maybe they do have some beneficial effect in the elbow, and they're still intact and you're 20 or 30 degrees shy, I'd probably leave that alone, frankly. I wouldn't go for anything more. If you already lost a condyle, so taking another bit off doesn't make much difference, and you want to finesse it out a few more degrees, and I think that'd be perfectly acceptable. My own bias is that I'd rather leave someone a bit shy of full extension anyways, because I've had the occasional patient hyperextend, which is horrible and almost incorrectable deformity. And secondly is that, if you look at the force on the interfaces in that elbow, they're extreme at the extremes of motion. I think the elbows I've had that have survived the longest, and people have like a 50 or 60 degree arc, they never loosen and they never wear, and they can get enough to get things done. And I'm not saying I aim for that, because I don't, but occasionally I end up with that, and I've never seen one of those patients loosen. The ones that have this massive range of motion where they impinge possibly the shin or they piston or whatever, those are the patients who tend to loosen. So in a crude way of thinking about it, this is an opinion, not fact. I think lacking some terminal extension, terminal flexion is actually protective for the interface of the component and leads to better longevity clinically. So those are kinds of things I'm thinking about when I'm trying to decide what to do. For these people who are fused pre-op, like this, I'm happy if the stem is in the bone on both ends and they have a bit of motion in the middle, because they're awfully hard cases to get something good out of.
A little change of topic. So obviously in my practice, the majority of the arthroplasties I'm seeing are traumatic. And I actually see a reasonable amount of heterotopic ossification in these patients. Is there any point where you do anything about that heterotopic ossification, both right after the surgery and in a delayed fashion?
Well, that's an excellent question. So for sure, HO is a problem with some of these cases. There's this tremendous healing response from the injury itself, and you have the second hit of the surgery, and you can get HO. So the answer is in selected people, I have gone to radiation for this post-op, and if I'm taking a total elbow back for stiffness and releasing it, and there's any HO, then they'll get radiation for sure on the revision. And if I was doing an ankylosis type case, then that'll be a case based on preoperative risk factors, I might consider giving that patient radiation for post-op.
I haven't gone to radiation, John, just because I have soft tissue concerns, and maybe I'm being weakling when I think about that, but I'm worried enough about it that way. But I'm pretty liberal with Indocin if I'm worried about it.
Would you do it routinely?
No. So it's for revision cases where there's HO, radiation, and for primary cases, for selected reasons like pre-op ankylosis or pre-op HO, then maybe I might do it.
Okay.
And I'll
What
say
about acute fracture? I mean, I see it a lot in acute fracture.
in general for that, no. The one thing I'll say about Indocid, and it does have some side effects, especially in older people. The second thing is Jim Kellum did a study back, it was a number of years ago, maybe late 80s, early 90s, where they gave acetabular fracture patients Indocid as a randomized trial. So you got a placebo pill or Indocid. And the patients had a research nurse call them literally every day to make sure they took the medication. They had their medication given to them for free. They had a drug diary, and every time they took their meds, they were supposed to write it down and bring it back and show everybody. And despite all that, at the end of the day, when they took Indocid levels from the people who were supposed to be taking Indocid, I think their hit rate was around 45%. So despite the best possible things you can do, free medication, a nurse calls you every day, write it down in the book, and your importance is explained to you, less than half the people took the medication. That's the problem with that. Radiation, you know you get what you get, so at least something happens for that patient.
Sounds like sling compliance after a rotator cuff or something. I mean, any others? All right, I think we got 10 minutes or so before we start the next, 5 minutes before we start the next session.